Good afternoon. So I have the privilege of speaking to you right after the coffee break. So either all of you are going to be going to the restroom, or you're going to be very caffeinated and fully energetic and just ready to learn and listen and talk and chat. That's right, yes. Talk faster, talk faster. And if I start talking too fast, you know I'm on my second cup of coffee for the afternoon. So welcome so much to this session. My name is Michael Swallow. I'm a movement disorder specialist or a movement disorder neurologist in Georgetown, Texas, which for those of you who don't know is just north of Austin. That name up there is pronounced Swallow. I know it doesn't look like that, but perhaps the only place in the country where people know how to pronounce that name is probably right here in New Orleans because it is Cajun. So hopefully all of you are enjoying the conference so far. I've got to say this is my first time to ever come to an HDSA conference. And, you know, I go to a lot of conferences, but very few are patient-driven and for patients and caregivers. And so I just think that's exceptional. And so I've already attended several sessions already, and they are amazing. And so I hope you're getting as much out of them as I did, and hopefully today you'll get some nuggets or tidbits out of this talk too. I got to tell you, this is so much more fun and so much better if you ask questions, you share stories, you have conversations. That's what this is about. So when they asked me about this topic, I said, wow, that's a lot of information in just a short time. But really, this is not to doctors, this is not to medical providers, this is to you, the patient, the caregiver, and what's far more relevant and more important is actually what you have to say and your stories amongst each other. And to me, I think that's the most crucial thing. So first and foremost, these are my disclosures, really not relevant here, except for I do receive grant funding from the HDSA, which I'm thankful for. We're a partner site at my institution, just north of Austin in Georgetown. Our Center of Excellence is at McGovern School, or UT Houston, which is in Houston, of course, and great representation here today from that group, and I'm very grateful and thankful for them. And then also relevant to today's talk, we're going to be talking about some treatments of Huntington's, and so I do consult and do some research for both Teva and for Neurocrine, both of whom have medications that are related to Huntington's. So here's the disclosure slide. So the information provided by speakers in workshops such as this, for example, are made as part of the HDSA convention. And remember, you're not my patient. And so it's really hard to give personal advice because I haven't had the privilege of having you as my patient or in my clinic. So I'll try to speak as generally as I can if there are specific questions about Huntington's, but please, ask questions. That's what this is about. And then we want to hear from you. This is my first meeting, and so if you're like, hey, this guy talks way too fast because he was after the coffee break, that needs to go into the eval. So take this QR code, take a picture of this, and then do an evaluation and let us know what you think. If there's something you didn't hear about or something you want to hear about, let us know. Because again, this is for you, and we want to make this as relevant as possible. All right? So first of all, we'll talk about what Huntington's is. Again, preaching to the choir, you guys know this. We'll talk about the stages of Huntington's. We'll talk about the signs from moving from early to mid-stage. Remember, this is Call for the Courageous, Battling Mid-Stage Huntington's. That's the name of the talk today. I'll tell you why I chose that talk in a minute. We'll talk about tips for success when you are with your provider team. We'll give you some tidbits that you can take home to really, hopefully, it'll make that clinic visit much more meaningful. We'll talk about motor versus non-motor symptoms and what that means and what do we do about it, and how that's relevant to you. And we'll also talk about strategies of symptom management, okay? there'll be medicines up here. There'll be sometimes words up here that may make sense, may not make sense. But if you don't remember anything from my talk today, remember this. Even though we don't yet have a cure for Huntington's, this is treatable, okay? And so I want you to know that, and I want you to leave those doors in the back feeling hopeful that we actually have treatment for Huntington's and for all the non-motor symptoms of Huntington's. And so we're going to go over some of those things today. I understand this is also being live streamed, and so thank you to those who couldn't make it in person and who are watching today. Oh, and before I start, I promised my 3 children at home that I would start off with a joke, because that's how I usually start off. And I see none of you have tomatoes, and so you're not going to throw them at me. But what do you call... I haven't even said the joke yet. Oh, you do have brains. They're like little squishy brains. There we go. Oh, I'll duck. I was like, man, this crowd's good. I haven't even started my joke, and they're already laughing. Nice crowd. What do you call a pig that does karate? A pork chop. Yeah. There you go. Just kidding. So I have three boys that will be very happy at home that I started with that joke. Okay. So first of all, let me just say, Huntington's, again, preaching to the choir, but Huntington's is a condition that affects the brain and the nervous system, and it is passed from one generation to the next. And why does that happen? Well, there's a mistake in the DNA which causes uncontrolled replication of the DNA, and it causes a number of different repeats. And there's a gene called the HTT gene, or the Huntington gene. And if you have 40 or more repeats, that is diagnostic for Huntington's disease. We all have these repeats, okay? But if we have too many of these repeats, things don't work right. And things start to happen in the level of the nervous system, and that's where we do genetic testing. And we are very blessed in Huntington's. I know it doesn't feel like it sometimes, but we are very blessed in Huntington's that we actually have the ability to do genetic testing. For example, I take care of a lot of Parkinson's patients, and it is not that straightforward to diagnose the 8 or 9 different types of Parkinson's disease. But yet, we have a genetic test in Huntington's that we can do and say for certain whether someone has Huntington's or not. It's inherited in an autosomal dominant fashion. Big words. Geneticists and genetic counselors that are here at this convention can go into much more exquisite detail there. But what that means is that you have a 50% chance of developing HD in your kids. And so the symptoms of Huntington's we'll get into quite a bit, but includes personality changes, mood swings, depression, judgment, gait, balance, movement problems. That's why we're here, is to learn how we can fix some of this and help some of this. And it usually begins in the mid-30s to 40s, but as you've probably heard today already, there are many pediatric or kids that have Huntington's, and they start very, very young with a very high number of repeats. And then my oldest patient to ever diagnose with Huntington's, who was barely symptomatic, was 86. 86. So, and there are some neurology colleagues that I've heard say, well, they're much too old for Huntington's, so don't even bother checking for that. But that is not correct. We always check for Huntington's. If we think about it, we check for it. And why? Because it really helps with expectations and counseling and all kinds of stuff, even if you're 86 years old. All right? So, lots of words on this. We're on this slide, but we're going to go into great detail about this. But the stages of Huntington's. So, I get asked all the time, Dr. Swallow, what stage of Parkinson's do I have? What stage of Huntington's do I have? And this is not quite like cancer staging, where you start off with one stage and then you wind up with the very late stage. Sometimes stages kind of go back and forth depending on when you have your symptoms and what those symptoms look like. And the most intriguing of all of these stages up here is the preclinical stage. What does that mean? That means if you have Huntington's, but we don't know it yet because you haven't yet displayed symptoms, that is extremely intriguing and very relevant, right? We are all searching for this cure, right? And so that is a wonderful stage that we can try to find a cure in. If we can diagnose Huntington's before it even shows up, is there something that we can later do that could prevent it from getting worse? That is the holy grail of what we're trying to do. So the preclinical stage, there are no motor symptoms at that time, but there may be some psychiatric symptoms. So a good example of this is if I have a patient who has been followed by psychiatry because they've had depression or bipolar, and they've been told that they have a big family history of mental health conditions like schizophrenia, or let's say that they've had trouble with the law, and Uncle Jimmy's had trouble with the law, and just, man, this family is just really impulsive, and they wind up really getting into trouble sometimes, and they pay for that by getting in trouble with the law and getting put in jail and in and out and all this stuff. But everyone assumes that it's because of mood problems or a psychiatric condition, and hey, schizophrenia runs in the family, right? Depression runs in the family, right? Bipolar runs in the family, right? But it's not until you start asking more questions about the family history and what happened to the family, and did anybody have unusual movements, or anybody have trouble with walking outside of just a regular cane or a walker when they were in their 60s? Were there family members that maybe passed away before their 60s? What's the story? Did anyone have very severe depression and commit suicide in the family? All of these plots thicken, right, when we start really taking the time to understand our patients. And then they come across our doorstep in the neurology clinic, and we do the testing, and we learn that, wow, this is because of Huntington's disease. And that's why there is such a strong history of psychological dysfunction and problems there. And that is eye-opening for years to come for that particular family. So again, very important that we ask the right questions, right? The early stage 1 of Huntington's, is characterized by mild motor symptoms. You may see some fidgeting or wiggling movements. You may see, some people that seem anxious or nervous. They may stroke their hair, or just kind of wipe their nose or their forehead when they wiggle or move. And those are involuntary movements, but they always get worse when, what? You're nervous or you're stressed. Guess what? Every movement gets worse when you're nervous or stressed. So a lot of times it gets mistaken for, well, they're just an anxious person. But actually there may be more to the picture there. And there's difficulty concentrating, difficulty with attention. And then as things move forward, as you can read, early and late middle stage, there's worsening movement, worsening gait and balance, some difficulty maybe walking or swallowing, more mood issues. And then stage 4 to 5 in the early advanced stage or advanced stage, there's far more disability in that stage. They need more help. Just doing their activities of daily living, bathing, brushing teeth, cooking for themselves, things like that. Here's another way of looking at it, far more, I think, visually appealing here, but you can see that front and center with the preclinical stage is poor emotion recognition. So that's something that actually flies under the radar quite a bit. Patients maybe are a little more irritable or angry, and as caregivers, I'm sure you can appreciate that from your loved ones at times. I'm sure we all could appreciate that at times, even if we don't have Huntington's. And there's more trouble with thinking and attention and memory and emotions that may fly off the cuff. And then I said legal matter trouble and substance abuse trouble, which I've alluded to already. That can last for about 20 years. And again, we're doing our very best to try to diagnose things early. And of course, if there's a strong family history of Huntington's and you know that already, it may be more obvious, but not always. Even in patients who they know they have a strong family history, and we ask our patients, do you suspect you have Huntington's based on what you're doing, how you're feeling, how you're moving? Many of them say, no, I don't have it. When in fact, when you look, they do. And the casual observer can see that, but we know that in Huntington's disease, we often have poor insight into the condition itself. So that's why I always love in my clinic to say, I love to have caregivers there because they will see things that the patient can't feel, just like the patient will feel things that the caregiver can't see, right? And so I love the more the merrier because it gives me a more full picture of what's going on. In the early stage, it lasts about 8 to 10 years. Again, I won't belabor this. I just mentioned it before, but these twitches begin, some subtle movements, as I said. And then the middle stage, which is really what we'll talk about today, or how do we treat these motor symptoms that evolve to chorea? And I think everyone probably here knows what chorea is. It's that involuntary twisting, writhing, dance-like movement. It's kind of funny. For the rest of the conference, I have a challenge for you. Any movement disorder specialist who talks about chorea, watch them. They will never just say the word, they will always act it out too. It's kind of a fun game to play. Pay attention to that. See if I'm wrong. Also, walking becomes more difficult. Balance. Sometimes patients feel like they're ping-ponging from wall to wall, kind of cruising along the wall at times because of balance. They may blow that off and say, I've always been clumsy, Lots of excuses there that can easily come up, but there may be more to the picture there if we look more deeply. And then one of my favorite things to think about and ask about is apathy. So a lot of times our patients, especially in middle stage Huntington's, will become more apathetic, which means, I really don't want to, don't really have a strong desire to. Are you depressed? No, not depressed. I just kind of don't want to do it, don't care, just kind of ambivalent, if you will. And then late stage Huntington's, again, 5 to 10 years or so. These are all estimates based on data, but chorea may start to transition from moving too much, as you've heard in other sessions, also rigidity and stiffness, kind of the opposite of that, right? All right, so I often tell this to patients with Huntington's, but I know this is meant a lot for caregivers, but it's for everyone. So I've just been diagnosed with Huntington's. No matter what stage you think you're in, what now? What do I do, right? Because most patients, using your words that you've told me and caregivers' words that they've told me, feels like a death sentence, right? That's what patients have told me. So step number 1 is to breathe. Take a breath. Relax. Pace yourself. There's a lot of information thrown at you. Especially if you go to a Huntington's disease center, there's a lot, it's drinking water from a fire hydrant, right? So for those of you who know this, think about the first time you've heard you or your loved one, Huntington's, entered the picture. Think of what that was like. It's hard, and there's a lot of information being thrown at you, and knowing what to take in and what kind of leaves the ears is hard. I used to have a professor that said, my brain is like an island of penguins. When one penguin jumps on, another one jumps off. So there's only so much room up there to store information. Well, especially so when you have this big, heavy news. Don't carry more weight on your shoulders than is needed. I think oftentimes we pride ourselves that we don't need help. Especially us guys, we can be kind of knuckleheads sometimes when it comes to that. Speaking for myself especially. But, we have family, we have friends, we have churches, we have organizations like the HDSA. We have these people here for a reason. And that reason is to help each other live life. Okay? We are called to a much greater purpose than just living in isolation, right? Build a support system. You'll need that from here on out. And then don't forget to thank your support system too. That's important. Know your options. So non-medicines, medicines, procedures that are available to treat Huntington's, those are all important. And one thing that I appreciate now more than ever, you, the patient, you, the caregiver, are your biggest advocates. And you almost have to be in this day and age. It's hard for clinicians. If you go to a general neurology clinic, sometimes my peers in general neurology only have 15 to 20 minutes to see a patient. How in the world do we tackle a complex disease like Huntington's in that long? Even if we have 30 minutes to an hour to see a Huntington's patient, it's hard to tackle all these things, especially if we don't get to see our patients as often as we want to. And on the flip side, from your perspective, there's so much information out there. What's good? What's not good? I had an 80-year-old tell me that she learned something off of TikTok the other day, and I was impressed. I don't even have a TikTok account, but she is all over it. But should we get our medical information from social media? And if we do, is it reputable? And what are we trusting? All these things are very difficult and challenging to navigate, but thankfully you have organizations like HDSA and of course provider teams that can help answer those questions. I know you've heard your primary care doctor say this 1,000 times. Eat healthy, exercise, it's very important, but guess what? For the brain and for movement disorders, especially Huntington's, it matters. It matters. And patients will tell us as soon as they stop exercising that they will notice a difference in their motor symptoms. Things will worsen. And so when you start back your exercise after a hiatus, then it gets better again. Your movement symptoms especially mood as well. So again, it is very important. And even better, do it together as a family. So nothing's better than taking a stroll around the neighborhood if you're able to with each other. And it's a good incentive to spend some good quality family time together, hopefully. And be honest with yourself, with your family, with your medical team. You know, I always used to pride myself that when someone enters the door of the clinic room and that door closes, anything's on the table, all things. And everything's up for discussion. But I find that to be more and more difficult these days, right? Because I see that some of our patients have more and more shame and guilt. I've heard a lot about shame and guilt today with some of the caregiver talks that I attended. It is easy to let that overwhelm you, but it shouldn't, especially with your medical team. So be honest with them and remember, as I said, it's treatable. So some more success tips here. Trust your provider team, but make sure they're listening to you. I'm sure you can have 1,000 stories of times when you didn't feel like you were being heard, right? Also, careful with reading side effect lists. I think more so now than ever, when we prescribe a medicine to our patients, obviously our pharmacy colleagues do good due diligence to really let everyone know what the side effects could be, and the FDA actually wants us to do that as well, as we should. However, it can be quite overwhelming. So I have many patients that will read through a list of side effects and choose never to take a medicine because they've read a list of side effects. But the far more relevant question is to know what to do with that list, right? If you have a question, ask your doctor. We always say that in passing, but there's a step before you decide not to take a medicine. Talk about it. Ask questions. That's what we're here for. And let us tell you the most common side effects, if any, our treatments have. And remember, we can't fix what we don't know, so talk to us. Talk to us about it. Treatment is a two-way street. You know, sometimes I'll have an hour-and-a-half long conversation with patients about everything that we have to treat these conditions, and at the end of that hour and a half, it's like, no thanks. And it does feel sort of deflating at times from the medical team, but remember, it's a two-way street. There are reasons that someone says, no thanks. And so we've got to kind of dig in and get to the bottom of that and find out what the barriers are. Sometimes it's cost, right? And so we have to deal with that too, and social workers help us with that, and pharmacies help us with that, and foundations help us provide those resources. Show up to your appointments early and bring your medication list. Okay, there are apps on phones. Technology can really be helpful here, and don't say nothing's changed, because it's always changed. That's our opinion anyways. And bring a friend or family member, like I said, And really, when things get tough, what I've noticed, and I've heard this already in our caregiver talks, is when things get tough, the visits get tough. And it often feels antagonistic, or it can, with your providers. And anytime it starts to feel that way, that's my red flag or clue that there's a lot of caregiver burden and that things aren't really thriving right now and there's some big problems going on, and that how can I help? What can I do? And I always find myself saying, remember, I'm on your same team. I'm on the same side. But sometimes it doesn't feel like that. I could tell you that from my perspective, and I know probably from your perspective too. So we have to take a breath and take a step back and remember that it doesn't help to argue, and we have to work together because we both actually want the same thing. Yeah? But we don't often think that, right? That takes practice to feel that way and take a step back and a bigger perspective. And so these are all tips that you have taught me and that we have observed that can really help things. Now, you'll hear about the motor and non-motor symptoms, and sometimes you have to pick your battles, and you have to know maybe what your top issue is that you want to address, because there's a lot of stuff to talk about, right? Huntington's is super complex, and so sometimes you may only get to one big issue, but remember, leverage your resources. Use what's around you. It takes a village to treat our patients with Huntington's, and we don't just leave everything up to our patients either, because, as I said, a lot of times when I ask a patient, well, hey, is your chorea, is your movement bothering you? They'll say, no. And then I'll say, do you ever have times when you're moving that you can't control, or that you're wiggling and you feel like you're kind of fidgety and dancing? And they'll say, no. And they're just a wiggling or moving. And that tells us that the brain connections are not working correctly, and that's why there's a disconnect there. So again, takes a village. A lot of times people can see things that the patient can't feel, and vice versa. All right. So this is just, it's hard to read, but this is just a schematic that shows that I can't do this by myself as a movement disorder specialist. And patient and caregiver is at the center, of course, but we've got nurses and urologists and GI folks and geneticists and clinical research folks and social workers and so on and so forth, all these folks out here. And it takes each and every one of these team members to really get to the bottom of how can we help you as a family unit. And so I rely on my colleagues and peers heavily to help out. So let's dive into some symptoms here. So when I approach treating Huntington's, I approach it from three aspects, I guess you would say. First is a motor aspect, so the moving problems. The second is behavioral or mood, kind of psychiatric problems, if you will. Little tangent. A lot of times patients have a stigma about going to a psychiatrist. And I say, would you have a stigma if you went to a cardiologist and had chest pain? No, because they're a specialist of the heart. If you had a stroke, would you worry about a neurologist? No. So if you're having mood problems, would you worry about a psychiatrist? Yes. No. We don't want you to feel that way, because they're trained medical professionals who understand the brain in a different way, although there is a lot of overlap between neurology and psychiatry. And then the last aspect of things is cognitive perspective. And this is one of my favorite graphics, is the tip of the iceberg. You've heard that saying. So the motor symptoms are what we see, but the complex thing to treat is everything below the surface, right? Impulsivity, constipation, sialorrhea or drooling, pseudobulbar affect, or PBA we call that. That's kind of increased emotions where you don't have a filter or a brake on your emotions. Daytime sleepiness, thinking difficulty, depression, anxiety, people that lack a social filter, or we call that disinhibition. Substance abuse, guilt, hallucinations, fatigue, apathy, pain, sweating, urinary urgency, all these things are things that we have to treat in a 15 to 30 minute appointment. Right? How can we do that? That's why we have to pick our battles, and that's why we have to see patients a lot, and we frequently get to know our patients very well. And when we lose our patients, it hurts deeply. Yeah? Because we get to see them very, very often, and we try to treat each and every one of these things. So my talk is Call of the Courageous. And does anybody know what movie this is from? Yeah, good job. Narnia, yeah. Lion, Witch, and the Wardrobe. So that is one of my absolute favorite movies. And so it may seem daunting when you're diagnosed with Huntington's or when you're at mid-stage Huntington's, because that's when things really start to unfold, right? And so could you imagine how they felt looking out over this battle and seeing all these folks about to charge them? I mean, that's what it feels like, doesn't it? It feels like that with Huntington's. You know what's coming. You know what to expect, maybe. And it's daunting. And so our role here is to help make that a little more palatable or a little easier to handle, okay? Because it does take a village, and it does take an army of folks to really help out. So let's dive in. So motor symptoms, chorea. So again, wiggling, movements. It can be usually suppressed, which means if I say, hey, don't move for a second, you could do that. But then it kind of comes back and it rebounds and it gets more. And the more distracted someone is, if they're thinking about what they had for dinner last night or whatever, that's when the chorea is more noticeable, or when they're anxious or nervous. And it can be very subtle to the point where maybe it's just a little twitch, to where it's very obvious and patients can't even walk because they're moving so much. And sometimes they'll disguise their movements unintentionally, the unintentional movements as intentional. For example, my shoulder wants to move and I'll scratch my ear or stroke my hair. And then why treat it? Well, because we're now learning through various studies that even though traditionally some patients with Huntington's don't really have the insight or aren't always aware of their symptoms at all times, actually when you treat their chorea, they notice improvements. And we know that patients notice it, and caregivers notice it, and certainly clinicians. And so even I was trained, does the movement bother you? No? Okay, we don't need to treat it. But things are times they are changing, right? Things are changing, and we now know that it actually does matter to treat movements early, because you can affect what happens in the future that way by treating the movements. And it improves quality of life, and that's a very important aspect that we really strive to treat. These movements are treatable, and we've seen a lot of different things through the years come out. And used to we would use strong antipsychotic medicines. I call them dopamine blockers, because traditionally, if you think of someone with Parkinson's disease, they don't have enough dopamine. So how do they move? Not very well. But if you think of someone with Huntington's and they have too much dopamine, how do they move? They move a lot more, right? That's too much dopamine means too much movement. So if we block dopamine or we get rid of dopamine, think of that like gas in your gas tank. Dopamine is like gas in your gas tank. If we get rid of that to a certain level, then movement starts to reduce and starts to decrease. And so we can treat that. But the problem with all those older medicines is they would make patients sleepy and gain a lot of weight, and they would have a lot of side effects, and that's miserable. So why would you want to treat it if it just made you feel worse, right? But then these newer medicines came about called VMAT2 inhibitors, and tetrabenazine was one of the first ones, and that actually depleted dopamine. It helped reduce dopamine in a different way, but we still had some of the side effects. And now tetrabenazine, also known as Austedo in the brand name, is available and FDA approved to treat Huntington's, and valbenazine is a different version of that VMAT2 inhibitor. It's not currently FDA approved for Huntington's, but it is being looked at as a possible treatment option for Huntington's. There's also other medicines like amantadine and certain muscle relaxants. And the recipe is different for each and every patient. So we have to listen to you, and we have to listen to our caregivers, and we have to learn from you, and you tell us what's working, what's not. And sometimes it takes more than one medicine to make that happen. And the side effects, as you see there, sometimes it is truly a recipe. You don't want to overdo the blocking of dopamine, right? So we want to reduce your movement and your dopamine just enough to where it takes care of the excessive movements that are troublesome, but we don't want to block it too much to where now you can't move, right? That defeats the purpose too. There's a sweet spot in there, and we have to find what dose does that. Balance and falls. So a lot of times we don't associate chorea with balance problems. We think, oh, I'm clumsy. But at the same time, folks with chorea do what? They get thrown from side to side. And that can be subtle, or that can be fairly obvious and fairly severe. So when we treat chorea, it actually can improve falls, and it can improve balance because it allows patients to be a little more steady on their feet. Sometimes my patients feel like they're being pushed, as they're walking. They feel like they're being pushed from one place to the other. And then adding a walking stick or a cane or a walker certainly helps reduce your risk of falls. But who wants that, right? There's a big stigma with that, and I recognize that. And there's a lot of inertia, or kind of a big rock to overcome when you finally make that choice to use something to help you fall. And I always say, I should say prevent fall, but I always say I like to be proactive rather than reactive, right? We like to talk about fall prevention rather than, oh man, now I've broken a hip and what do I do now? Now I'm bedbound for a while. That really affects your quality of life. So adding a third leg like a walking stick or a cane can really help promote better balance. And remember, other things happen too in Huntington's. It's not always Huntington's. Back, stenosis and arthritis, neuropathy where your nerves don't work well if you have diabetes, for example. All of that makes walking in balance a lot more difficult. So we have to kind of really take care of ourselves as we're monitoring for balance and falls. And so that's where our PT and occupational therapy colleagues really come into play. They help us tremendously. And I hear patients a lot of times say, well, I can do that on my own. No, not like our therapist can teach you. Now, by all means, what do our patients not do when they get discharged from PT and OT? Keep doing their exercises, right? And so it actually helps you stay focused on your exercise when you go to a PT and an OT, and I'll add on speech therapy as well. Their goal is to teach you what you need to do specific to you, but then the goal is to continue doing that with a trainer or an accountability partner and at home. Dystonia. Dystonia is something that gets overlooked at. Fancy medical word, but what does that mean? Part of motor symptoms in Huntington's, among other movement disorders, is kind of a tightness, twisting, turning that causes movements on their own. So you may have seen babies have what's called torticollis when they're born, perhaps, and it goes away on its own. But with Huntington's, you can get a lot of muscle stiffness, neck stiffness, a lot of tight muscles just by twisting and turning. And that is called dystonia. That is a movement disorder, and we have treatment options for that. And the analogy I often give is imagine a rubber band being tightened, wound, tight as you can go right before it breaks. It is miserable to be that tight and tense all the time. And what does that do to anxiety? What does that do to mood and sleep? It's hard, but it's treatable. That's the point. So you just got to be aware of that. So range of motion exercises and stretching certainly helps, but the problem with dystonia is as soon as you do those wonderful things like acupuncture, massage, all those things, it clinches right back up. And so that's why we often turn to botulinum injections. You've heard of Botox as one of many brands. Xeomin is another brand, Dysport, Myoblock. All of these brand name medicines that are injectable, we're not talking about cosmetic purposes here. We're talking about movement disorder purposes. its job is to relax the muscle, but it keeps it relaxed for 3 months at a time. And then imagine stretching and range of motion and PT and OT and how much more effective that can be if it's treated. And insurance often pays for that because it's a medical indication. So that's just something to keep in your back pocket, that if you have that, it can actually be treated and improved. Okay? Now, switching from motor symptoms to mood symptoms, depression and anxiety. So on the blue list here, you can see some common features of depression. Depressed mood, loss of interest. Insomnia means you can't sleep. Hypersomnia means you sleep too much. Weight gain, weight loss, right? People stress eat or they don't eat. Everyone has a different reaction to depression. Decreased energy, worthlessness, guilt, concentration difficulty, wanting to kill yourself. And sometimes, if it's severe enough, even seeing or hearing things that other people can't see or hear, hallucinations, we call those. Those are all symptoms that could indicate depression. And it occurs in 45% of patients with HD, and usually even more in early HD, actually. And seeing a counselor or therapist is ideal. And if you treat depression and anxiety with counseling versus just medication alone, you're much more effectively going to treat the depression and anxiety when you combine those two things than either one alone. So which means the best way to overcome your depression and anxiety is to see a counselor and to have medical treatment. When you combine those two things, it is much more helpful than if you just did one or the other. Hope that makes sense. And then exercise. If you haven't tried this, try it. When you get angry about something or you get anxious about something, you walk outside, you take a stroll around the block. It's amazing that you will find the anger eases down. And it's not just a matter of time. It's because you're physically moving. You're thinking, you're moving, you're displacing that energy, and that is super helpful. And so do that, and do that as a family. That's even better. But oftentimes, sometimes our patients with HD will turn to substance abuse to actually help with their anxiety. They'll turn to alcohol or drug use to help with their anxiety or their depression, and that's a slippery slope too. So when we talk about treatments, we want to talk about healthy ways, healthy treatments to treat these things. And the mood chemical that we often refer to is called serotonin. And we've talked about dopamine as one chemical in the brain that helps us to move, think, poop, pee, all kinds of things. Serotonin is another one that really is very affected in Huntington's, and it's low. So guess how we treat depression and anxiety? We give you back serotonin in some way, shape, or form, and we do that through different medicines. Like antidepressants. They're called SSRIs, like sertraline, citalopram, etc. There are many, too many to list here. There are newer agents, too, that have been shown to be helpful for mood, and then therapy, and then trying to avoid triggers. Do you know how many times patients will retire and all of a sudden their mood gets better? I'm not saying that work is bad. Work is great, but it's not always great. Some people do have hard jobs and stressful jobs, and it really takes its emotional toll, and that really does affect your mood. And so you want to try to avoid triggers, or at least still deal with these triggers in a healthy way. And we often use psychiatry colleagues to help out with this with our patients. Anger and irritability, short fuses. Man, that is so common in my HD patients and our HD patients. A lot of times there'll be an abrupt, unpredictable outburst of anger, and wow, didn't see that coming. And that is a very common symptom. And then what happens after someone does that? They usually feel guilty, and they feel sad that they just did that. And remember, that is your Huntington's. That is your brain not working correctly. That is not you as a person. So again, very important to think about that. And if if you could beat depression and anxiety and irritability and anger on willpower alone, none of us would be talking about all this stuff right now, because we have a bunch of really strong folks with Huntington's, right? Very strong willpowers. But we need help in that time when we're we're angry or we're depressed. We need some professional help to kind of see a different perspective at times, and that's where it can be very helpful there. Exercise, again, very important even with anger and irritability, and serotonin also plays a role in that as well. So how do we treat it? Well, one thing to think about is, I talked about dystonia earlier, that tightness of your muscles. If you're stiff and you're tight all the time, it's amazing what that does for your mood and how short and irritable a person can be if they're in pain. So that's always a good first place, actually, to start by asking you and our caregivers, do you have a lot of pain? Is that contributing to this? And then we treat that. Psychotherapy, again, is helpful. Other medicines like you see here. Again, don't want to get bogged down on the names of the medicine here, but the goal here is treatment. So anger and irritability, they are all treatable, but it often takes different recipes for different patients. Apathy, I alluded to this earlier, so that's that indifference to things, less concerned about things. I used to love to play golf. Now I really don't care if I do or not. It's just too much effort. I used to love to take pictures of birds, and now I don't even enjoy going outside. Again, you may think that's depression, but not always. Now, they can happen hand in hand with each other, but not always. Sometimes it's just apathy, and that's something that happens in over 70% of our HD patients. And this is something that is a little more difficult to treat than some of our other things like depression and anxiety, but we have to be a little more creative at times to try to treat apathy. And there are certain stimulants that have been shown to be effective in apathy. Amantadine is another medicine. And then some of our memory or cognitive medicines can be helpful for apathy. And then sometimes levodopa can be helpful for apathy. I've heard of levodopa. Oh yeah, that's a Parkinson's treatment. What? I don't have Parkinson's, I have Huntington's. But again, dopamine is a very important chemical in the brain, and sometimes we have to use it to our advantage and leverage that. And so apathy is something that we sometimes use levodopa for. Now, many of you may know about impulsivity or disinhibition. So what that means is that there is inappropriate or unwanted behavior that our patients may have a difficult time withholding. That's called disinhibition. And impulsivity is the trouble controlling urges or acting on thoughts, even if it means it would be hurtful to another person. I can't say this enough. This is your Huntington's. It is not you as a person. It is not our loved one as a person. They are not purposefully doing these things. It is a sick brain that's not talking. The connections aren't talking correctly to one another. And it's important to think about that in the moment. Because one thing that I see caregivers do a lot is get very frustrated when, for example, they know they're going to fall. Don't get up and move. You're going to fall. What did you do? You got up and moved. And just roar, hear me, And that's something that's very valid. That's a frustration that many of our caregivers have. But remember, the brain, especially the front part of our brain, tells us what to do and what not to do. And when it's probably not a good idea if we do something, and when it's a great idea if we do something. And when the front part of the brain's not working right, especially in Huntington's, a lot of times we don't have that ability to figure that out. And so if you look at it through, as a caregiver, if you look at things through that lens, it will help ease frustration a bit, and it will help you not be as angry with your loved one when it seems like they may have selective hearing, or selective listening, I should say. All right, hallucinations. These could be quite scary at times. Seeing people, seeing animals, someone, hospital worker, I put an example, a hospital worker stole my tractor at my house. Doesn't make a lot of sense, but they believe that, and there's nothing you can say or do that will change that. that is something that is hard to treat, but treatable. And delusions or false beliefs, as you see, illusions is when you're mistaking something from something for something else. For example, I see a coat rack in the room, but I think that's a person instead of a coat rack. And remember that when things are great, and then all of a sudden out of nowhere, your loved one's having hallucinations or delusions just out of the blue, remember that infections, even something as simple as a UTI, urinary tract infection, a bladder infection, that's something that's a common cause of that. So cognitive, as we wrap up, cognitive changes. So cognition is more than just memory. Memory is certainly a part of that. Memory and learning, language, how we communicate makes up a person's cognition. Their executive function, which is their ability to plan, organize, carry out tasks, control attention, inhibit impulsive behavior, which we've talked about. Attention is the ability to focus and sustain attention. Most commonly when people say, I have a memory problem, it's attention that they're referring to. They lose track of their glasses, which are on their head. I've done that before many times. We all have that to a point. But that's something that can be even more common in HD. And then social cognition, the ability to understand and respond to social cues. That's a big one. So what are some strategies? What are some practical things that you can do as caregivers to help with some of these cognitive changes? So first of all, you've heard the term, use it or lose it. The mind is a muscle. You have to exercise it. So playing video games isn't always helpful there, but working puzzles, reading, keeping up with current events, being engaged in discussion, that is a memory exercise that you and your loved ones can do, and it really does make a difference. And there are fancy ways to do that through games and modules online that you purchase, and there are easy ways to do that too. Going to the dollar store, getting a bunch of Sudoku books with different, varying levels, and just, having fun doing that, but really thinking about it. Getting enough sleep. I'm sure we've all been there when we don't get enough sleep and we can't think straight, right? It affects the way you think. And guess where you restore your memory and your mind and your thinking? In your sleep. So when you get poor sleep, things don't work right the next day. Now throw on top of that Huntington's, right? Exercising regularly, use a planner or calendar. Setting realistic goals, go into 6 doctor's appointments in one day. That's exhausting, right? So being mindful of that, taking breaks when you need it, listening to your body, asking help. I heard a wonderful talk earlier in a caregiver group, session, where when someone offers you help, take them up on it. When they offer to cook for you, take them up on it. It will help. A little bit goes a long way there. And use technology to your advantage. So there are apps that help patients remember their phone, to take their medicines on their phone. There are even apps that alert you if a medicine was missed and the patient didn't take the medicine. Again, technology can be quite helpful. The other thing is to really attempt as a caregiver to simplify things as best as you can, but don't talk down to the patient. That's a fine line, and that actually takes a lot of practice. You don't want to nag your loved one at doing certain things. That's never helpful. You want to be their cheerleader. You want to be their companion and helpful to them, not hurtful, of course, but sometimes it can come across. But remember, they can't read emotional cues a lot of times, so they see you as nagging, but really all you're doing as a caregiver is just trying to help them and doing your best to help them in every way possible so that they're not having to worry about it as much. So that is something that I see quite often, and being mindful of that and practicing that mindfulness is very helpful. Keep your questions pointed and simple, and especially your medical providers. We need to do that when we're seeing our HD patients. As I said, it becomes more challenging to read emotions. And then how do we treat cognition? Well, we have several medicines that we use, which can be helpful, but certainly games, puzzles, keeping up with things, discussions. When I see someone's cognition worsen the most is when they get isolated, they don't go out, they get depressed, their interaction stops from the world. And if ever I have patients that are really bogged down on their disease, or caregivers that are really bogged down on the disease, one of the best ways to get your mind off of that is actually helping other people. So volunteering and helping other people, whether that be at church or at something like this, or at a support group, can be very, very helpful in dealing with depression, mood changes, cognitive changes. So you remember this picture earlier, right? It can seem daunting when you look out and you see what's coming towards you. And we always say the fear of the unknown is the scariest. But that's two ways. Not knowing what to expect is scary, but when you see what's coming, that can be scary too, especially in Huntington's. But remember the other side of that. You've got an army behind you willing to help you. You've got resources all around you. Of course, I'm preaching to the choir because you're here at this conference and those listening online. But remember that we're here to help you and your family get through this. And there's a lot that needs to be done, yes, but we have come a long way. So don't forget about the army behind you as you move forward battling Huntington's. Thank you for your attention. Questions? Any questions? Right here in the front, and then we'll go to you next. Yes, sir. Excellent question. The question for those who didn't hear was, if I can reword it slightly, should you be scared to start a medicine early for fear that it may stop working in the future? And then what do you do when things do get worse? How do you help it? So in our movement disorders, you never develop a tolerance to some of these medicines that work on dopamine. Whew, that's a good thing. What that means is if there's an abnormal movement present, we should never be scared to start a medicine to treat it. Okay? So because it's not like it'll stop working at some point in the future. Now, unfortunately, what happens and why it may appear to stop working with time is because the disease worsens with time. So if my dopamine system in the brain is getting worse and worse and worse at regulating things, and my movements are getting more and more and more, then it may take more and more and more medicine to get the job done. Not because the medicine is not effective, but because my brain needs that much medicine to accomplish the task. So, as I said, it's a recipe with time. So we may start off with a low dose. Start low, go slow. That's always our motto and most of the time in movement. But as things worsen, we may need other medicines on board to create that perfect recipe for that patient to accomplish the goal of helping their movements. And remember, we can't solve all the movements. Our goal is to dampen them down. When people get emotional or nervous, they still have movement, as they should, So we want to just dampen down the movements that are problematic for them. So it's an excellent question and one that we often hear and one that I often see keeps patients from wanting to get treated earlier because they're worried their medicine won't work in the future. Yep. Yes, sir, right there, you had a question. So the question is, are there any medicine in the pipeline that are helpful for the movements in Huntington's? And the answer is absolutely. There are medicines coming down the pipeline that are helpful. I won't go into all the detail today because they're technically not FDA approved. They're in the pipeline. But there are a lot of wonderful studies being done to help out with that. Some of which I'm sure you'll hear about as the conference goes on. So I think it's a very hopeful time in Huntington's because we really do have a lot of wonderful trials and a lot of trials looking at older medicines but used in a unique way. Maybe something that's been around for a while, but we've never really considered it as a treatment option for these various things in Huntington's. There are also trials looking at some of those. Yes, ma'am. So the question is, when someone is in any type of facility, group home, any type of facility, and there are behavioral issues from the Huntington's, and the staff members or maybe even other residents or patients may not understand what's going on. How do we deal with that? Great question. So the first thing I always say is the best way you can advocate for your loved one is by teaching. A lot of times people at facilities or group homes may not be familiar with Huntington's. And if you can teach them that is a common thing in Huntington's and it's actually a treatable thing, then it's a different perspective. It's a perspective of the illness is causing this condition as opposed to it's disobedience causing this problem, or it's defiance causing this. That's the disease. It's not the person. That lens goes a long way. So directors of nursing at these facilities can be very helpful there, and your provider team can be very helpful there too. So again, teaching or little notes to the staff that when there are outbursts of anger or things like that, please keep a log of that. Let us know how often that's happening, because if it is, we want to be able to treat that, sometimes medically, sometimes not. And then figuring out what the triggers are, perhaps. And the hard thing is they're taking care of other patients as well. So no one's going to be able to advocate on their behalf better than you, the loved one. So I always say spend a little more time there, figure out what's going on, the trigger, and then teach. And that's the start of a very complicated process to try to fix something that's broken. Should the patient be punished for having an emotional outburst? No. So, and again, I think that's education that goes a long ways, and it's them seeing things through a slightly different lens, that these are the diseases that actually cause these things, not a person being rude or mean or disobedient or defiant. Maybe one more question, because I know I'm 4 minutes over, but in the back here. Yes, ma'am. Would you mind if I repeated what you said just now for everyone to hear? So what she was saying, that she's a nurse and has worked at places like that before, and so you can imagine turnover, shift change, etc. Lots of things get lost in translation. So if you can make little notes as the transitions happen, or maybe ways that that particular patient likes to be calmed down, or different triggers that may rev up that patient, that communication is very helpful. And so I think those are excellent points. Thank you for that. And then your question. So the question was, at what point as a neurologist do we choose to bring cognitive medications on board? And so the cognitive medications don't really slow down the worsening of cognition, unfortunately. I wish it did. What it does is it helps the process happen more efficiently. So you can imagine processing, and then you start the medicine, and what that can do is help processing be more efficient. And so we usually, just personally, I bring on those medicines when it starts becoming more of an issue and the patient or caregiver really starts complaining that, listen, they can't even get through one sentence because they're having to pause so long, and we just can't get anything done because it's really taking so long for them to get their words out and think and all that stuff. To me, that's clearly a time that a medicine would be appropriate there, if not before. So once patients start complaining of that and having difficulty there, that's when we try to bring those on, because it really is seen as a symptomatic treatment, not so much a preventative treatment. So I just want to be clear on that. I wish we had a preventative treatment for that. So I've hoped that you have left here feeling a little bit hopeful that there are a lot of different things involved with Huntington's, but wait, it's treatable. Still searching for that cure, but I hope you leave here with some nuggets to take back home to your team. Thank you so much.